Hey everyone, I'm Dr. Bastian, Medical Director here at Aeon Future Health. I'm here with Dr. Melissa Fougere. She's one of our naturopaths who's helped create the gastroenterology gut health program. She has done her master's in neuroscience from
Memorial University of Newfoundland.
University, that's right. And then followed that up with naturopathic medicine in Vancouver, and now has comes to us to discuss more gut health topics. And she's spoken to other physicians, taught other gastroenterologists on the topics of gut health and IBS. So, Mel, thank you very much for joining us.
Oh, I'm excited to be here. I love talking about the gut. It's my favorite.
Excellent. So, really just to get started, we see so many patients who come to us who are struggling with gut health issues.
Yep.
Either bloating, constipation, diarrhea, gas, and yet the conservative healthcare system really hasn't provided them the answers that they're looking for.
Yeah.
Can you tell us a little bit about why that is?
Yeah, I think the conventional system is set up to assess patients with blood work and imaging. And unfortunately, if you're looking to decipher what's going on with someone's digestion, there are other labs that are required. We'll get into that and talk about those, but stool testing and breath testing. And then I think the other issue with the conventional medicine is it's more set up to treat based on symptoms, right? So a patient's got a lot of reflux, here's an acid blocker. A patient's got IBS, put them on a motility medication. And so I think treating the root cause is maybe where a naturopathic doctor and our co-carer would really shine.
Yeah, absolutely. And I think what's so interesting about that is, in so many of our other fields of medicine, you do get that root cause.
Yeah.
But the trouble is the GI system is so complex. It's not just one thing.
No.
And to really find a solution, you have to look at those things fairly individually. So can you sort of run us through what a good motility, good digestive tract system looks like, and then that'll help set the stage for what things can go wrong.
Yeah, for sure. So it starts with mastication, so chewing. It's actually one of the only times we mechanically break our food down, besides the stomach churning it. Next, once the food makes its way through the esophagus, we're into the stomach, and so stomach acid becomes really important. So the parietal cells releasing hydrochloride, and then that acid environment's really involved in denaturing proteins and killing bacteria and harmful substances that we might be taking in. Next, we're into the small intestine, and so bile is going to be released from the gallbladder to help break down fat, and then our pancreas is really the shining star here. It's releasing, lipase and peptidase and amylase to break down our carbohydrates, our fats and proteins. And this is where most of our nutrients are absorbed. So our small intestine has a very large surface area for nutrient absorption. And so if there's any inflammation going on there, malabsorption can definitely occur for our nutrients. And then last, we've got the colon, which is mostly involved in reabsorbing water and electrolytes, and it's where most of our bacteria is. So there's trillions and trillions of bacteria in the colon, and that's where we want it to be. We don't want there to be a bunch of bacteria in the upper part of our small intestine. And then, of course, elimination would be the last step.
Yeah, perfect. So, really, there's a lot of pieces, both in terms of motility and secretion of enzymes. And then, of course, the gut microbiome that we're going to talk about, and they all play a role, which is why, personally, I think one of the hardest things about the conventional care system is if you only treat one piece of the system, you're not necessarily going to get the result that you're looking for.
Never.
Okay. And then so when we're looking at, what we do and how we do it differently, what are some of the things that can go wrong, that we see most commonly? And then, to me, it seems like there's a difference between acute causes and chronic causes.
For sure.
And the more that I've learned about it, the more I understand that really it's oftentimes there's multiple things going on at once. So maybe you could just lay out sort of some common pathways for what happens in the gut.
Sure. So I think it's important to rule things out like celiac, pancreatitis, gallbladder stones. So running blood work to rule some of that stuff out seems really important. And then there can be issues that can develop more chronically that you may not be thinking of. So for instance, food poisoning. is a big one. So even a mild case of diarrhea after traveling or eating can be enough to damage your motility in such a way that you may be crippled with digestive symptoms like long term. And so how that works is the bacteria can release a toxin that affects your peristalsis. And so then cells and food and bacteria aren't moving out of the gut the way we want them to. And so that's when the bacteria starts to accumulate in the small intestine, and we start to get the symptoms of IBS, right? So bloating, loose stool, gas, sometimes constipation. And actually, like a bacterial overgrowth, or SIBO, is probably the number one contributor to IBS symptoms that's often missed.
Yeah. And so, you talked a little bit about peristalsis. Can you describe that a little bit more, how bacteria impact that, and, perhaps discuss how it's a bit of a self-fulfilling cycle?
Yeah, so there's a really special type of peristalsis in the small intestine. It's called the migrating motility complex.
Yeah.
And
peristalsis really just means the movement, the coordinated movement of muscles within your gut pushing food down the
you can think of it like a slinky, kind of moving things through. So roughage, food, bacteria. It happens most after eating and during periods of fasting, and it's really important to clear things out so that the small intestine is available to absorb nutrients like it's meant to. And so, if the bacteria creates inflammation in the intestinal lining, damage occurs to the proteins and the parts of that peristalsis that are needed. And so then the migrating motility complex doesn't function the way it's supposed to anymore.
Right. Okay. And then again, when you don't have that migrating motility complex functioning the way it's supposed to, that MMC, right, then you get more bacteria where it's not supposed to be.
That's right.
Right. And you end up with, which then again further causes that disruption of that motility, which is why we often talk about IBS being a combination of your gut microbiome, what's going on with your gut, but then also a dysfunction in the motility.
Yeah, I think at its heart, IBS is a motility dysfunction, whether that's slow or fast, and the accumulation of bacteria in the small intestine where we don't want it.
Right, okay. And so let's talk about, that small intestinal bacterial overgrowth. Can you discuss what the disease is and then also what the test is?
Yeah, so SIBO, S-I-B-O, small intestine bacterial overgrowth, really refers to more bacteria in the small intestine than we want. And so the diagnostic criteria is a certain number of bacteria present that's higher than what's expected. So most of our bacteria should be in the colon, and so if too much ends up in the small intestine, when we eat, that bacteria ferments our food, and so we start to get gas and bloating throughout the day. So it follows that it's best assessed with a breath test.
Right.
So you drink a little sugar solution, and as that makes its way down through your small intestine, if there is an overgrowth of bacteria, it will ferment that sugar. And so we're measuring levels of hydrogen and methane gas. And those shouldn't be there. And if they are to a certain amount that's considered positive, then you're diagnosed with that condition.
Right. And so really, what may start with a episode of food poisoning, then you have bacteria disrupt this motility complex. You end up with bacteria that are supposed to be in the large intestine, really make their way up into the small intestine, and where it's very normal to have bacteria in the large intestine that consume carbohydrate and make gas. I mean, that's what leads to like passing gas, right? When you get that in the small intestine and those bacteria shouldn't be there, all of a sudden you get the same release of gas, but now it causes bloating, discomfort, burping, all those other things.
Yeah, absolutely. And it's almost like worse as you eat. Like one of the things I'm looking for in a patient to determine if they have SIBO is if they say, my belly's pretty flat in the morning, and throughout the day as I eat, I get more and more distended and bloated. And then, ironically, those patients actually are worse with healthy foods. So that's another thing I'll watch for. If a patient says, if I eat legumes and onion and garlic and higher fiber foods, like really bloated and uncomfortable and gassy. And that's that bacteria fermenting those foods.
Yeah, okay, got it. Now, that's part one, looking at the small intestine. Of course, we also have a look at the large intestine or the colon.
Yep.
So tell us a little bit about what that test is and what it means to assess.
Yeah, so the SIBO test is really only assessing if there's a bacterial overgrowth in the upper part of our intestine, so in our small intestine. It's really important to also look at the colon, so the large intestine, and this is best accomplished with stool testing. And so the comprehensive stool analysis is my personal favorite. And it's a pretty thorough exam of what's going on in your large intestine. It starts with a culture, so it looks at whether or not you've got enough of our beneficial bacteria. So are we able to grow things like lactobacillus and bifidobacteria in the amount that's expected? It looks for yeast, so are we able to grow and culture an overgrowth of yeast? Now, yeast is a natural inhabitant of our digestive system, but it can certainly become overgrown and create a whole pile of symptoms, which can mimic SIBO actually, and so it's really great to know about both things. It'll check for what's called a dysbiosis, so a disharmony of your biome. So there's other bacteria that are kind of considered freeloaders. They're not really doing a ton for us, but not considered like pathogenic. But we don't want those to be overgrown either. So it'll check for that. And if there's too much of any of those species, we'll eliminate those too. And that's just the culture. Yeah. It keeps going. And so we'll assess what's going on under the microscope. So we'll check for parasites pretty thoroughly. It's a very large exam for parasites. It also checks for dead yeast. And so yeast can also be like higher up in the small intestine. So it's referred to as small intestine fungal overgrowth. And that can be hard to catch in a stool sample because a lot of times that yeast is dead by the time it makes it into the large intestine, and so we can't culture it and grow it. So we're able to visualize that under the microscope and then based on a patient's symptoms, treat that as well. PCR testing is included, so it's important to make sure there's not a virus. If a patient's got some diarrhea going on, is it just a virus? In which case, we don't want to give antibiotics, right? Pathogenic bacteria is assessed for via PCR. And then my favorite part of the test is the chemistry.
Yeah, okay. So tell me, so really what you're painting is like the picture of a fairly complete assessment of the gut microbiome, which is important because everybody hears about gut microbiome and it's, I think the key thing that's important to understand is although understanding what your gut microbiome is in general as like a roadmap is informative.
Sure.
Really the value of a lot of these things comes down to the treatment and the elimination of specific bacteria, yeast, and parasites. Yeah. And again, if you don't know what you're looking for, you're going to end up with a whole bunch of information, but with no action items to do. Yeah,
no, absolutely. I think you want to know everybody that's in there so that if there is a pathology or a dysbiosis, you can treat them systematically without trying to guess empirically based on a patient's symptoms, right?
Yeah.
So definitely, I think, gives a full, complete picture of who's in there, who's good, who's bad, and then what we want to do about it.
Awesome. And then, okay, so let's move on to the chemistry. Yeah. Tell me a bit about that.
Yeah, so chemistry, I feel, is a really important part of this test, namely because it looks for inflammatory markers. And so oftentimes a patient may look like they're experiencing symptoms of IBS, so irritable bowel syndrome. We want to make sure it's nothing more serious, right? So irritable bowel disease. And sometimes IBS can mimic some of those more serious conditions like ulcerative colitis and Crohn's. And so the test checks for lactoferrin and calprotectin. Calprotectin is a really important marker to make sure that you assess. It's secreted by white blood cells into the digestive lining when there is inflammation going on, and you really can use it to diagnose irritable bowel diseases. There are a few other things that may cause slight elevations of calprotectin, like a major bacteria, pathogenic dysbiosis that's in there. Sometimes, use of certain medications can contribute to it, but it really helps determine whether or not we're dealing with something more serious that needs to be, imaged and worked up.
Yeah. Yeah. And which I think is awesome because the tendency is for patients and physicians alike to either go one of two ways.
Yeah.
Either they say, look, all IBS is nothing. It's all in your head or just a little bit of heartburn, and here's your symptomatic management.
Yeah.
Or they go the flip side. Yeah. They say, well, this needs a scope and a full endoscopy. And that's, while that's a very safe route, it's not always the best utilization of resources, and it often doesn't give you the answers you're looking for anyway.
No.
The other thing that I think is what I have found personally surprising is some of the other tests around like pancreatic enzyme production and stuff like that, because it's been amazing to see how some pancreatic function, which really are the enzymes that help patients to break down food and carbohydrate properly are so critical to this pathway. Can you expand on that a bit?
Yeah, so fecal elastase is another one of the markers included in the chemistry panel, which is a breakdown product of pancreatic function, and you want lots of elastase in your stool sample. And so if elastase levels happen to be low, you can use that to diagnose a condition called exocrine pancreatic insufficiency, so EPI for short. Basically a fancy term for the pancreas is not releasing enough enzymes to break our food down. The main symptoms of EPI would be like bloating, gas, diarrhea, foul-smelling stool. Sometimes there's fat in the stool. And you know what? I've seen constipation a bunch of times in my EPI patients as well. So it really does mimic SIBO, right? So it's really important to get all the information from that colon test to make sure that a patient has SIBO and EPI, or, one or the other. One of the things that can occur if you have that pancreatic condition is your SIBO can be quite a bit worse. So you can imagine that if the pancreas isn't breaking carbohydrates down, there's more food for the SIBO. So it's almost like an all-you-can-eat buffet for your small intestine bacterial overgrowth if your pancreas is also functioning poorly. Now, most of the time, that pancreatic condition is idiopathic, so I want to say 25% of the time. But it's great that we're a co-care team with a medical doctor involved in the care, just to be sure that we're not missing, a more serious cause of that pancreatic issue. Yeah.
Yeah, for sure. And the other thing that I think is unique is, again, in the conventional care system, that pancreatic enzyme, what they deem to be pancreatic insufficiency,
right,
they're only going to capture that at like the absolute end stage of diagnosis.
Yeah.
And like everything in healthcare, we know a lot of this sits on a spectrum, right? And so being able to capture it, I think, in some of the earlier phases makes a lot of sense. And the last thing that I'll say is, you need that pancreatic enzyme to break down the carbohydrates in your food. So if you haven't broken those down, then those larger pieces of carbohydrates now make their way into the small intestine and large intestine. And they're not supposed to be that way, right? They're supposed to be much, much smaller. And then all of a sudden you have these large particles that are contributing, and now the bacteria in the small intestine can just go wild.
And it can be quite debilitating, and also very satisfying as a practitioner. Sometimes giving a patient prescribed enzymes is kind of life-changing. Oh my God, I didn't know that I could feel this way. And so, it can be quite uncomfortable to be bloated like that when you're not breaking your food down.
Right.
Yeah.
So, to really recap, we have the SIBO testing, which is a breath test to look at the small intestinal bacterial overgrowth. Are there bacteria in your small intestine that are producing either hydrogen or methane that contribute to a lot of those symptoms? And then, the CSAP testing, the large intestine assessment for all of the things that we just discussed. So that gives a very clear picture, especially when you couple it with some extended labs as to what you're looking for.
Yeah.
So let's move on a little bit to treatment. So let's say you have a patient, they come in, they've done the lab tests. There's no major red flags. Yeah. They have a positive SIBO test, as well as maybe some things that you're noticing on the CSAP testing. Yeah. What does treatment look like for that patient?
Yeah. So I think it's really beneficial to have all the information up front so that you can make a plan on which thing to treat and tailor the treatment to the individual. And so, for instance, if a patient has a yeast overgrowth, probably I'm starting there. Because yeast is so opportunistic, even a natural herb that's eliminating bacteria may allow the yeast to grow and consume more nutrients. And so, normally we'll start with yeast treatment. Most often we're using prescribed antifungals combined with herbs. And then it's really important to make sure that you're doing something to support what are called biofilms, even with yeast. And so biofilms are these kind of protective sheaths that are produced when yeast and bacteria kind of clump together. And it can make it really challenging for antifungals and antibacterials and antibiotics to actually do their job. So it's really crucial to make sure you're opening the biofilms, and then we'll get in there with antifungal treatments, and then reassess the patient as needed. So yeast is usually where I would start. If there's a colon bacteria that's overgrown, if possible, it's nice to have some overlap in terms of what you're using. So both biofilm again to make sure that the bacteria is ready to be killed, and then we'll use antibiotics and herbs to eliminate those bacteria.
Yeah, and one of the things that I found really interesting is the treatments that we use to eliminate things like yeast and some of the other antibiotics from the gut, they don't really have very much systemic absorption, right?
No.
Like the vast majority of it stays within the gut tract.
Yep.
And so one of the things that I've found very interesting as well is if you just used herbals, right, you might end up with, or biofilm agents, you might end up breaking down the cell wall, helping to break down the biofilm itself, but not actually get to the bacteria and eradicate it. Similarly, if you go the more conventional route, physician route, and you get treated with either an oral antifungal or an oral antibiotic, it's a great antibiotic, but it might not get to the core of the cell if it's trying to push through, these biofilms and these hard cellular membranes. And so one of the things that I really like is the fact that we use a combined approach.
You bet.
Because it's a really effective way to address these bacteria or yeast or parasites, and then access them and then eradicate them.
Yeah, I would say missing the biofilm busting is probably the most common pitfall of treating these conditions. If a practitioner isn't accounting for that, a patient may actually feel amazing when they're on their antibiotics, which makes sense. The bacteria is like, let's go away for a bit. And then they feel a lot worse again once they take away that therapeutic intervention. So yeah, I love that we combine the biofilm busting with natural herbal antimicrobials, prescribed agents, which is super unique to having a medical doctor on board, right? So.
Yeah, it's a great balance. And then, so let's say they've gone through those initial steps, right? You've eradicated the yeast first, as an example. Moved on to perhaps eradicating some of the bacteria in their small intestine if they have tested positive for SIBO. What do the follow-up steps look like after that?
Yeah, so certainly we're keeping track of symptoms. So how's your bloating at a 10? What are your bowel movements doing? And a lot of the times things are better, which is really exciting to see. And then we can always retest. So it can sometimes be really beneficial to check that a yeast is gone or no longer overgrown, and to check our progress with treating the SIBO. And so that may be completely gone. We've fully eradicated the bacteria with our intervention. Maybe that we've knocked it down a little bit. Let's keep going. It may be that we need to switch gears and pick something else. So you can use testing to help determine how effective your treatment's been.
Yeah, for sure. And then, so, that really focuses on part one, which is the eradication of these bacteria, right? But like we talked about, there's this cyclical loop with motility.
Yeah, absolutely.
And if we don't address that piece as well, a lot of times you'll get partial relief because the bacteria is gone, and then gradually things will return. So maybe you can touch base on that a bit.
So I think at its heart, SIBO is a motility disorder. I think it is the number one root cause of this condition. And so unfortunately, if you don't address that, you're going to get a relapse of this condition. And I would say the relapse recurrence is really high for something like SIBO, especially if you're not looking at motility support. And so that's what we do. We make sure that we're improving motility. It's almost like you're retraining that peristalsis, almost like physiotherapy for your digestive system. And there's natural agents that we'll use for that, and there's prescribed agents that we'll use for that. And it's a really important part of reducing SIBO from coming back.
Yeah, for sure. And so, I think our listeners are probably beginning to get a picture, which is like there's this eradication component. Which is best done with an integrative approach. Then there's the maintenance of the motility, which is really important to help against recurrence. And a lot of times both of those things will end up causing like a fair amount of inflammation, as you're going through. So maybe just chat a bit about how we kind of address that component. And then lastly, sort of what we might do for patients for, seeding healthy bacteria.
Yeah. So there's always going to be an increase in inflammation if there's a bacterial overgrowth, right? And then that inflammation damages your peristalsis lining. And then that can actually worsen motility. So it's sort of like a snowball effect. There's a bacteria, it's creating inflammation, motility slows down. So we got to move the motility, but it's also really important to get in there with some healing nutrients to heal up that intestinal lining so that the motility can be more like long-term supported. And so, we'll get in there with nutrients, sometimes peptides is another thing that we can use to kind of enhance healing. And then that also helps to reduce the recurrence of those conditions.
Yeah, for sure. And one of the things that I think is really, again, interesting and exciting is there's different types of peptides, which are really small protein molecules that can help to, help signal different things. And one of the most common ones used with the best evidence is called BCP157. And if you take it orally, it actually does a really good job of decreasing inflammation within your gut.
Yeah.
And so when we use that in conjunction with some of these other things, you can end up with a treatment plan that is way better from where you started. Yeah. And also has much less likelihood of recurrence.
Yeah, absolutely. Like we're reducing the recurrence and then we're also healing it up, right? So we're improving your overall intestinal lining's health. So think better nutrient absorption, less inflammation, less risk of autoimmunity, better mood, immune system, all those things.
Yeah. And do you find, like, in terms of the role of pre and probiotics, like, do you find any value in those?
Yeah. So, as mentioned, part of the culture or PCR testing is your beneficial bacteria. So what's your biome looking like? And so if you are deficient, once we've improved the motility, eliminated the overgrowth, of course we want to get in there and support those good guys that needed help. And so, prebiotics might be great. Soluble fiber can feed kind of everyone, which is probably my preference. But every now and again, I will get in there with a specific strain based on that person's stool test and then support some of the deficiencies.
Awesome. Yeah. Awesome. Well, I think that's a really clear overview of what we've been talking about. Is there anything else you want to touch base on?
No, I mean, I think digestion is complicated, and I think the more information you have, the better you are able to tailor a treatment to the individual. And I do think that it's important to do things in a specific order. So making sure you're opening biofilms, making sure that you're killing the bacteria, and then making sure that you're doing the motility and anti-inflammatory support so that a patient continues to have improved digestive health.
Yeah, and the only last thing that I'll say is one of the things that I think is really exciting about what we're doing when we're looking at good bacteria as well is we're beginning to understand all of the different areas that a healthy gut microbiome contributes to.
For sure.
Right? Yeah. So it contributes to things like your immune health in a dramatic way.
Definitely.
It has a substantial impact on serotonin production and your mental health.
90%.
And it's actually also really, really important for how your body metabolizes and cycles estrogen.
Yeah.
And so these are all things that, we knew, of course, we initially wanted to treat it so patients would feel better. Yeah. And I think like many of the things that we look at, once we get closer under the lens, we recognize that, well, not only is it good for how patients feel,
sure,
but it's also good for how patients live.
Yeah, I mean, our gut health is really important for immunity. Like you said, I want to say like 80% of our immune system is controlled by our intestinal flora. Definitely serotonin. Like 90% of our serotonin is produced in our intestinal lining. Definitely metabolism is another kind of new area where our gut biome is starting to show some therapeutic indications. And then, looking at like autoimmunity and brain function and just overall health, right? Reducing inflammation in your gut reduces it kind of everywhere.
Yeah. And, in North America, we've really normalized having all of these digestive issues, right? So, and part of that's from our diet, part of it's from our lifestyle.
Yep.
But if you go to the pharmacy, you'll see things that are things like, Tums, acid suppressants, over-the-counter PPIs like pantoprazole, stomach acid suppressants. And those aren't meant to be long-term medications. Like those indications, the indication for those medications was always short-term.
Yeah.
And now we've sort of like internalized that it's an okay thing to have.
Yeah.
When in fact, there's probably a ton of things that are going on that we've just kind of deemed to be a regular part of the day.
Yeah, I mean, I'm very much a data practitioner. Like, I like to know what's going on in a patient before treating. So maybe it's tempting to go buy supplement A, B, and C designed to control symptom 1, 2, 3. But, in my opinion, actually running those tests and then knowing what's going on and then treating that, it's just more effective, right? And you're going to get better results.
Yeah, absolutely. We initially thought this testing was really just for people who had gut health issues. Right. And I think now we're beginning to understand that actually, even if you don't have any major symptoms, there can still be dysbiotic bacteria at play. So, maybe just generally talk about what are the classic symptoms, what are the patients that should be coming in, for symptomatic management, and then other areas that you could see this being valuable for in the future.
Yeah, certainly we think about gut testing for someone who's got bloating, gas, changes in bowel frequency or consistency, heartburn, reflux, all of those things. And so both those tests are indicated in a patient like that. But I'm also thinking about gut health for a patient who's, got mood disturbances. So anxiety, depression, a patient who's got a lot of stress. I'm wondering what their gut biome's looking like and how that's impacting inflammation in the body. Anyone with an autoimmune condition would likely benefit from digestive testing. And then we'll use it to support metabolism, weight loss goals, longevity even, right? So if we're looking to kind of just enhance health overall, I think looking at our digestive system is a great way to do that.
Absolutely. And I also think that when patients have come in initially with gut health related symptoms, let's say to their conventional care doctor, right? And they've been put on a PPI, a stomach acid suppressant like Pantalog for the last 5 years, and they're like, well, my symptoms are pretty well maintained or controlled. I certainly have thoughts on that. Like, I'd like to hear yours.
Yeah. I mean, I think, something like a PPI certainly has its place. If a patient's having like chronic recurrent reflux, like that's not ideal. It could create changes in the intestinal lining that are dangerous. So sure, they have their place. But I think the long-term use of medications like that and suppressing our stomach acid, it can impact nutrient absorption. So think like B12 and iron, magnesium, and then it can further contribute to things like SIBO, right? So we're not breaking that bacteria down.
Yeah, exactly. So, when you take patients who have had heartburn in the past, number one, often have motility issues off the get-go. And number two, when you take something like Pantalog or a stomach acid suppressant, right, you're no longer breaking down the food the way it's supposed to be broken down. Furthermore, your acid isn't as acidic, and you're going to have more bacteria that can survive in that environment. And what we see, and I know this because we often run patients through testing, and we look at their B12 and their iron. Is when patients are on these medications, they often don't absorb those nutrients as well, because those are the nutrients that get absorbed through the small intestine.
That's right.
And so I think I think conventional care doctors are doing the best they can with the resources that they have.
Yeah, of course.
But at the same time, if you're one of these people who say, look, I have heartburn or I've had indigestion, it's well managed on X, Y, and Z medication. Yeah, I mean, that's great for symptom control, but it's certainly worthwhile looking for another deep dive in case there's a secondary root cause of those features.
Yeah, and I think if you're someone who's had chronically low levels of B12 and iron, hypothyroidism, rosacea, these are all conditions associated with SIBO. So maybe we want to check to see if that's maybe potentially contributing. The bacteria actually eats your iron. And then, of course, if there's any inflammation, then we're going to absorb less, right?
Yeah, for sure. So let's say you have a patient come in and you run through the program. They do their initial testing. They go through the components of eradication, reseed. They're feeling better. When or if would you retest?
Sure. I mean, each case is individualized, but for the most part, we want to check for the SIBO eradication right after we're done. So how are we doing with that bacteria? Is it gone? Before we move on to the relapse prevention. And then stool testing, certainly if there's, blood detected in the stool or if calprotectin was there, we do want to make sure that we're rechecking those values. And you can actually use calprotectin to check for how effectively you're treating someone's irritable bowel disease. So I guess, loosely we would want to confirm that our eradication was successful once it's been completed.
Yeah, for sure. Which I think is great. And, the other thing that often happens with patients is they get caught between two spaces. They see their family doctor. They have bad heartburn. They get treated with some medication. Then they get referred to gastroenterology. Right? And the GI docs, and I think as a patient, you would assume that the gastroenterologist is going to have like a clear understanding of how this works and how to treat it. And many times they don't, as you know.
No, yeah. I mean, I think it's changing and getting better and better. I think there is more focus on motility and the biome in gastroenterology than there used to be. But yeah, I think that's where we would maybe be a great added benefit to a patient's health.
Right. And a gastroenterologist is going to test you for specific things. You know, they might do an endoscopy where they put a camera down and take a sample to make sure that you don't have things like celiac disease or inflammatory bowel disease. But if you come up clean on that test, and you feel like you have kind of run out of options because that's not the area of that gastroenterologist's specialty or expertise, you know, there's certainly a ton that can be done between, you know, what they're providing and what we're providing to help sort of move things forward.
Yeah, absolutely. I mean, I've certainly seen patients that have been referred from gastroenterology to be tested for SIBO and to do some of those other functional tests that may offer some kind of key information that wasn't able to be checked by them.
Yeah, and what I really appreciate is the structure of how we've kind of laid out the program. I think really allows for a very targeted, individualized approach. And I think it's also really helpful so when patients leave the program, they understand what's going on with their gut.
Yeah,
you know?
Of course, yeah.
And I feel like for most patients who struggle with these kind of issues, it's really sort of, it's up in the air, they have some indigestion, they don't know why or how or what can be done about it. And sometimes that information piece is also incredibly helpful.
Yeah, it's fun to offer some hope. Like, hey, there's this thing we can test for and treat and it might help. You're like, all right.
Awesome. Yeah, totally. Well, thank you so much for helping to tailor the program. And for leading the charge on that. And thank you very much for that explanation today. That was great.
You bet. Fun talking with you.
Awesome. Likewise. Thanks.